Yes, ma'am. Am I
Yes,
audible?
good. Yes, yes. Now you
Yeah,
are.
yeah.
All right. Timer
Sorry.
I've started, and here is the question. Yes, please.
Be hypotensive. I think.
Yes, why it became
Yeah.
hypertensive? All right. So if you've read and understood, kindly tell me how are you going to manage this patient?
I'm considering the scenario. I would like to manage the patient according to the CRISP protocol.
Yes.
And the patient is obviously in post-op, so I would go by A to E approach. I'll check the airway first to maintain the. I mean, check that it's maintained. Then I'll look for the breathing. If the breathing is fine, I'll move on to circulation. In circulation, I'll check for the heart rate, blood pressure, the urine output, the capillary refilling time, if possible, including the JVP, and the urine output of the patient by the hour. Um, in this case, the patient is shown to be hypertensive with tachycardia and desaturation. So there is an elevation of new score, early warning score, and there is oliguria as well. So I would suspect that there is a fluid loss. Hypertension doesn't.
Doesn't fit
I'm
in.
a
Yes.
little.
Why?
I'm. It looks as if the patient is actually in fluid overload because the flow chart show that the patient has been given 7 liters of fluid.
Yes. So how would
Almost
you
overload.
manage? What
I would compare
criteria would
the.
you? Yes.
I would compare the urine output as compared to the intake of the patient. So I would look at the intake output chart to see how much of fluid overload is happening, and
Yes.
accordingly, if there is overload of fluid and the patient's output is decreased, I would consider giving some diuresis for removing the excess of fluid in this case.
Okay. What if patient does not respond to the fluid challenge? What would you do next?
Wouldn't do a fluid challenge in this case because it's already overload. There's
Yes.
already excessive
So
fluid that's been given.
how would you manage that if it's overloaded? Then how would you
I would consider
make
diuresis, and
sure? Yes.
if it's working, if I can give furosemide and start off and try and look at the urine output if it's improving. If the patient is not responding to diuresis, I would have to consider maybe dialysis in case. I'm not sure if that is
Okay.
right.
What would you do? Patient is going desaturated, becoming oligouric, and you
So
think
yeah,
patient has been over? Yes.
desaturated. So I will actually start giving supplemental oxygen. Check
Yes.
for the saturation improvement with supplemental O2. We can provide a nasal O2 or give oxygen with a non-rebreather mask if he's not responding to. I mean, if the saturations are not improving with nasal O2.
Yes.
Um, I would check that there is an equal air entry on both sides, and I would check that I would rule out any fluid overload by checking for any basal crepitations, and also consider doing a chest X-ray in this case.
Okay.
Then again in
What do you
circulation,
expect to find on chest X-ray?
if there is fluid overload, that could be basal. Minimal pleural effusion, and could be curly brie lines on the base,
Yes.
and on auscultation there could be fine crackles that I can appreciate more on the basal areas, infraaxillary, inframammary, and basal areas.
If patient is uh, uh, overloaded or fluid overload, then how would you expect ABGs to be?
Patient, that could be acidosis, ma'am, if
Yes.
there's fluid overload.
Would
With
there
the
be
excessive
metabolic or respiratory?
will be metabolic acidosis
Yes.
along with the increased base excess
Yes.
with the with respiratory compensation.
Yes. Then what measures would you do to manage saturation or?
Uh, I would improve the improve the saturation with oxygenation. and try and control the acidosis.
Yes.
I'm sorry, ma'am, I'm not sure about the management in that one.
Okay,
For
we
the
can
acidosis.
discuss. We can ask Dr.
Yes.
Others, Dr. Suman,
Yeah,
Dr.
yeah.
Abhishek.
Can I go to the next question, ma'am, please?
Yes. Okay. Right. What is the role of furosemide? Patient was already on furosemide and is becoming oligouric now. So, what is the role of furosemide?
So basically,
How does it work? Yes.
acts by causing diuresis. With the sodium, chlorine, and potassium. It inhibits that symporter in the ascending limb of loop of Henle.
Yes. Okay.
It
What went
thereby
wrong
reduces.
here? What has happened? Why it isn't working the way it should have been?
Most probably, there was initially less amount of response to the fluid challenge, and as such, they have overloaded the patient with multiple amounts of fluid, and now the
Okay.
patient is having increased fluid retention.
Yes.
And in detailed examination, I would also look at the post-op notes as to what the patient has undergone, as to what the surgery was as well, to rule out any other septic causes also.
Would you consider giving thiazide to the patient?
Yes.
Why? What would it do?
Thiazide is also another diuretic which can actually
Yes.
improve the fluid overload in this case. So it will
Okay.
act by acting on the DCT and decrease the sodium absorption over there,
Very
and
good.
it will
And
improve the diuresis of the case,
okay, good.
thereby removing the fluid excess.
All right.
And also, yeah.
What about 4 liters of normal saline were given? How this normal saline acts?
So that would cause increased amount of sodium to be remaining in the intravascular compartment,
Yes.
which will in return cause increased water retention. So we
Yes.
basically must try to remove the excessive sodium that is inside the circulation.
Yes.
Yeah. So that is
Yes.
in turn exerting an osmotic effect.
Yes. Okay. Close my. Okay, patient is tachycardic as well. Why do you suggest patient has become tachycardic?
Um,
And what measures would you do? What investigations would you do to make sure patient is
um,
safe?
in this case, obviously we have to focus on the circulation. So we look at the vitals, and then if there isn't, as per the early warning score, we'll actually look at the saturation and the vitals and everything. Then we can do a chest X-ray, like I mentioned. Then by in labs in bloods, I would actually look for the
Yes.
renal function studies of the patient, including
Yes.
the latest urea and creatinine and serum electrolytes, especially to look out for any electrolyte abnormalities. I would also look for any long-standing renal impairment if the patient is known to have any pre-existing renal condition which is causing fluid overload, or any infective pathology which is causing organ failure secondary to
Okay.
sepsis.
Who
I
would
would
you
also think in that.
involve in the management of this patient?
So for this, I would definitely involve the renal team, the registrar or the consultant from the renal physicians,
Yes.
and I would also consider an input from the ITU team
Yes.
in case the patient needs to be escalated to the HTU or ITU.
Yes.
I would also inform my consultant on call, who is, who should be aware about the case in order to know the progress about the patient. But
Okay.
also take an input from him.
Can you tell me? Right. Question was. I'm sorry. All of a sudden, question went out of the mind. Okay, you'll. Right. Sorry, time even went. I'm sorry. I'm trying to
Okay,
recall. I
ma'am. Let's
had a
keep going.
question in my. I had a question in my mind. Oh yes. What are the complications, immediate and long term, of fluid overload? Please.
Overload. There could be electrolyte abnormalities again. I'm sorry, ma'am. I'm not. I've read up on that.
Take me from the beginning till to the end, until the
About
death or the cerebral edema, or wherever you
yeah,
can take me.
cerebral edema, intestinal.
Wherever you can take me in a rhythm, like in a systemic way. That's why, yes, you knew this one was your topic yesterday. You
Yes, but
said it.
Electrolyte abnormalities. There could be fluid overload, again respiratory
Yes,
failure.
yes. First thing, okay, respiratory failure. Then, all right, that didn't work. Buffer system, acid-base balance, all got disturbed. Now, even if getting renal system being involved. Okay, then what's happening? And why patient? Why have I written hypertensive, not hypotensive?
I'm not sure about that. I think I need help in this question.
They are writing, but they are not talking. Yes,
Oh,
please.
sorry. I didn't have a look at the chat. Sorry.
Yes, good. You didn't. I even didn't. Yes, it should be fluid overload.
Fluid overload topic. Yeah.
This is
But
what
why
the
tachycardia and a fluid overload? I don't understand.
yes, that's why I'm asking you. This is advanced stage, I'm telling you, like, okay,
Yes,
and
ma'am.
that's why I'm
That is.
asking you. That's why I'm asking you to take me from the beginning to till the end. This patient, all right, it's post-op, but this is not the right immediate situation. In immediate, all right, it becomes hypotensive,
Yeah.
and then all right, and then when it
Oh,
becomes patient deteriorates
right.
towards
At the end. Okay.
then yes, it becomes hypertensive, and then already okay, then everything goes. But
You
yes, Dr.
talk.
Abhishek, would you want to tell?
What, ma'am?
Yes, post-op, these complications of fluid overload.
Ma'am, it's like we should not stop for any question. Like we can say at what comes into our mind, like this fluid overload.
Yes, Dr. Sridhar did very
First of
well
all,
Yeah.
accordingly, but
yes,
then
yes, yes.
I'm not satisfied now.
No, no, it's okay.
Yes.
Now, first of all, you look into the brain, it may cause the cerebral edema, okay,
Yes.
mental
Okay.
alteration, convulsion, something, and it may lead ultimately to death. And second of all, it may cause pulmonary edema, and there will be impaired gaseous system
Yes.
that may lead to that may lead to like type 2 respiratory failure, and eventually
Yes.
for this respiratory failure patient get dead. And then come to the cardiovascular system, and due to this fluid overload, the heart will fatigue after some time,
Yes.
and the heart will not be able to compensate. If we don't give the early management for this patient, there will be a congestive cardiac failure. And
Yes.
there will be hepatic congestion, peripheral tissue congestion. For the
Yes.
hepatic congestion, there will be liver alteration and liver failure. And for the peripheral congestion, there may be some kind of ankle edema, facial puffiness, engorged neck pains. You can find that. And then
Yes.
comes the renal system.
Yes.
So this is already a case of acute renal failure. So fluid overload has caused renal failure for this patient, raised urea creatinine and all the.
And then post-op
Yes.
case as well. That's also contributing
Case,
to
yes,
renal failure as well.
Renal
So,
failure, yes, ma'am.
yes.
So I think, and also it will cause the gastrointestinal congestion. There may be some
Yes.
due to some kind of stress and impaired gastric motility. There is chance of gastrointestinal bleeding, ulceration, and due to the septic attack, there may be some kind of bacterial translocation, and patient may lead
Definitely,
to
yes.
lead to septicemia. So you can say like this, Dr. Sridhar. Like don't say
Yes.
like I don't know.
He'll
You
just,
can you know
he'll
I
just,
definitely know that you
everything.
know this.
He knows.
Yeah.
Yeah, I
It's
just had a mental
it's
blackout.
just
Sorry.
no.
Yeah,
That's why we practice. Once you are practicing and overcoming your fear here, then you'll be it will become spontaneous. Everything. Yes, Dr. Mohammed. It will come spontaneously in your mind. Like Dr. Abhishek has been coming to these meetings for a year, about a year now. It has become spontaneous for him. Like he doesn't have to sit and think for too long. He just comes up with an answer quickly. Plus, this is physiology. You have to read little physiology of renal
Can
system.
I just I just wanted to double check on one confusion that so you're saying that this is basically tachycardia because of end stage renal failure where there is excessive fluid loss, and that is why the patient's having tachycardia. So like
Fluid overload, and then that is like advanced stage right now.
end stage. Okay.
Hi, can I just add
Yes,
something?
please. Yes, please.
Yeah, I think in this scenario where the patient is a post-operative patient and there
Yes.
is a hypertension
Yes.
along with decreased renal or oliguria,
Yes.
I think it's worth considering renal artery stenosis.
Okay.
Perhaps because that will cause on one end the hypertension, and on the other hand
Yes.
it might lead to oliguria.
Yes.
And that's why maybe the patient is also being given fluid challenges and not responding. Another thing I remember reading about oliguria in post-op patients
Yes.
is checking the catheter in the first steps in your initial management of the patient, checking
Yes.
whether or not the catheter is blocked in the first instance.
This is the first, yes.
Before even giving fluid challenges.
Yes.
Or the other thing is it's important to, I think he mentioned checking the operative notes and
Yes, he
going
did.
back to the patient's
Yes.
medical history and
Yes.
these things. But it would be also maybe important to check what sort of surgery did the patient have.
Yes.
Maybe a renal transplant surgery. Is this a rejection reaction? I mean, they can, as you know, they can
Yes.
expand on any topic.
Anything, yes.
But I don't know what exactly is. What did we agree that this is the which scenario is this? Is this fluid overload or is this a post-operative complication?
This is fluid overload of my scenario of fluid overload.
Yes, and Dr. Mohammed, actually, this is the scenario of fluid overload due to the some misconduct by the junior staffs of the hospital. They gave more fluid for the patient that was allocated for than the allocated fluid. So that's why you have to just treat the patient according to the management of heart failure. Okay.
Yes, I did try to make bring him, but then it's all right. He'll go back and he'll read little physiology of cardiology, little renal, little respiratory, how all these systems are connected at the end. What happens towards the end, then how many systems get involved and how the body reacts. So basically this.
Yes,
Ma'am, I just want to add something for Dr.
Yes,
Sridhar. Dr. Sridhar, actually, for this station, there is also an important question, that is, what may be the cause of oliguria of a post-operative patient?
Yeah.
There are 6 points you can make, like from the 2 notes we follow. I'm not mentioning the name. Okay,
no
so go through that because the
ones,
points are really important, like some kind of heart and some kind of renal renin-angiotensin system, and post-operatively patient may get patient may get oliguric due to release of vasopressin or release of stress hormone, and there may be lack of overlapping of interdigitation of actin and myosin filament that will just increase decrease more cardiac output for this patient. So that is one point. And another point is a case of I have mentioned already, that it should be managed as heart failure. So 3 points of drugs you have to remember, like preload reduction, inotrope reduction, and the inotropes 1. You will get that on the books also. So I'm just focusing on the important things. So these things are very vulnerable to be forgotten.
If you remember, if for whatever the scenario is, if you remember these points can come and they will be helpful for any scenario.
Any scenario,
yes. Because post-op acute kidney injury happens. It's like something very common. It can happen. So any scenario you will get in critical care, this will come handy. So it's better to read how all systems are really interrelated. And the basic thing is first, whatever happens, first respiratory system comes in action. When that fails, then only kidneys come in action. And they're not right away. So you have to understand. Make a connection of them and stepwise, sequence-wise. Yes, good. It was very interesting. And how Dr. Siddha takes the challenge of difficult topics, that's also very brave. Right, Dr. Mohammed Al-Tahir, thank you. You waited. Anyone else want to? Yes, Dr. Ishfaq, you raised hand. I'm sorry.
Ma'am, what we discussed about the hypertension, what is the cause of hypertension and this tachycardia in this patient? Is it the fluid overload itself, or is it the sympathetic drive and the catecholamine release in this patient? What is the exact pathophysiology of tachycardia and hypertension?
Yes, exact. I myself don't know. I've written a scenario, but you can just think, imagine.
Yes, a stress drive. It is, ma'am, a stress drive.
So you are saying it's due to the catecholamines.
Yeah, because it is post-op patient already on stress drive.
No. We are not talking about the post-op patient. We are talking about the hypervolemia in this patient. Patient is having fluid overload.
Yes,
so
but
what
patient is hyper post-op.
Yeah.
Yes,
Patient
is
has
hyper.
preload has
post-op.
increased, but afterload is also increased in this patient.
Both preload and afterload are raised.
Both are increased.
Yes,
Preload
both.
increased due to the fluid overload, and
Yes.
this afterload is increased due to the stress, all stress response.
Yes.
Okay.
And this renal means kidney response by activating renin-angiotensin aldosterone system. It further causes afterload increment.
Fluid tension and this.
Yes. These all together causes hypertension and tachycardia. And finally, this stretching of the cardiac muscles which fails, because after certain limit, if you this cardiac muscles stretches, this actin and myosin cannot properly get aligned, and it cannot contract. Yeah, properly.
Yes, we're talking about the Frank-Starling law. Yes.
Yeah. You are right. Frank-Starling law.
Okay. These are the basics, you have to go that low, because sometimes they realize that the candidate does not have a fresh basic knowledge, so they trap them in these simple questions. Many times it has happened, like a very intelligent candidate, but they have not revised freshly these basic things, and then they get trapped. Like, you have to know the connection, you have to know how everything is happening.